So, hey, first off, I want to just say thank you guys for coming, and those acts are really tough acts to follow. I'm like legit shaking in my ballet slippers right now, which is... But I wanted to give a special thanks to Dr. Quinn for giving so much great mentorship, and Drs. Hernandez and Brown for being amazing seniors for this. And Dr. Hernandez and I, kindred spirits, thought, you know, Vegas, drunk dude, hangover, obviously, that's pretty much a gimme. Other key points in history we want to mention here. So this is a pretty young dude, Afro-Caribbean male. Always think about your patient demographics. Left side of the abdomen, that's a pretty big differential, but it gives you at least somewhere to start. 4 days, that's putting you more in like the subacute phase as opposed to the acute abdomen. And then he was on a flight, so I don't know if like, you know, a DVT is going to give you vomiting and left side belly pain, but there's things to think about. He was on a plane. Drinking, vomiting, things that you think about drinking, obviously pancreatitis, alcoholic ketoacidosis, alcoholic gastritis, so on and so forth. But I want to focus more on the left side of the abdomen first. So the best thing to do with a belly exam is think about like what are the organs that you're dealing with. So left side is like a bunch of them. But as ER docs, we're never going to forget about the heart and the lung. And then moving downward, I'm not going to list off all of the differentials. It's obviously a teeny, teeny little print there. But the stomach, pancreas, spleen, and colon. Those are things that you want to think about, as we mentioned, especially with alcohol, gastritis, pancreatitis, and then left side, hello, spleen, let's be real. Colon, diverticulitis, things like that. But back to our friend the spleen. Whenever you're thinking about the spleen, it's a supravascular organ and it's connected by vasculature to the liver. So keep those things in the back of your mind while you're thinking about them. So our physical, as Dr. Hernandez mentioned, he's tachycardic, he's febrile, but let's be real, our big player here is going to be your spleen. He already explained Schwab space to you. But yeah, he's got splenomegaly. So what are we thinking about when we start to think about splenomegaly? We're thinking about 3 different types of splenomegaly, or etiologies of splenomegaly. First is going to be your hyperplasia, hypertrophy, which is going to be increased demand of your spleen. So the spleen is responsible for getting rid of messed up cells. So you're going to have like your reticuloendothelial system. So if you have any messed up red blood cells, then your spleen's going to be working really hard and it'll get big and beefy, like Dr. Beta. And then any of the immune demands on the spleen, whether it's on purpose or disorder, and then extramedullary hematopoiesis. Also passive congestion. Anything that keeps the blood from going out of the highly vascular spleen is going to cause the spleen to get bigger, full of blood. Other stuff is infiltrative diseases. So anytime you put something in an organ, it gets bigger, whether it's a deposition or a neoplasm. So moving on to labs, I did bold them, but I'm a junior. So we have leukocytosis, and we do have a mild microcytic anemia. But he's a young guy. He really shouldn't be anemic at all, especially because he's healthy. And he has this bump in his retic. But other than that, our other target organs, remember we're talking about the left side of the belly, so our kidneys are doing just fine. And the AST and ALT are really unremarkable. But this bili, so we have an elevated total bilirubin. And anytime you're talking about hyperbilirubinemia, you want to know is it conjugated bilirubin or unconjugated bilirubin, because that changes things drastically. So our direct bili, which is going to be your conjugated bilirubin, is only about 20% of that elevated bilirubin. So we have an unconjugated dominant hyperbilirubinemia, and then a lipase of heart emoji, aka less than 3. So our smear is going to be where we put on our like hematologist caps, and we're going to talk about that right now. So teardrop erythrocytes apparently are also called dacrocytes, fun fact. And they're associated with hemolytic anemias, thalassemias, and other things I listed up here. So somatocytes are going to be alcoholism. Wait, he was in Vegas. Does that mean something? Red cell membrane defects, and then you have like target cells that are also associated with hemoglobinopathies. So we're thinking like, this is a red blood cell. Whoa, what is all of this? This is a huge list. What am I supposed to do with this? This is, oh man, that's a hyperbilirubinemia differential diagnosis. That is nuts. Okay, I don't want to deal with all of this nonsense. Okay, so if only I had like a special skill set that would help me narrow my differential. Oh wait, I do. I'm an ER doctor, so I'm going to use my physical, my labs, and I'm going to get this way more dealable. So we have, like we said, it's an unconjugated hyperbilirubinemia. So see you later, conjugated hyperbilirubinemia. I don't need you right now. Decreased clearance can also go by the wayside because he's not in CHF. And he's not on any of these meds that you can't read right now because there's like X over them. But also, defective conjugation. So you have Kriegel and Nager. I don't think you guys can really read all this, but I'll read it to you. So you have Kriegel and Nager type 1 and 2. One's fetal in infancy, so we don't need to deal with that. And then there's like, if he's on ethanyl estradiol, which he's not. Other things here are Kriegler, Nager type 2, and Gilbert, as well as hyperthyroidism. None of those things are really linked to splenomegaly, and they're not really consistent with the presentation that we're getting here. But what do we have? We have our smear again. Yay, smear! So it's really leading us down toward that, like, hemolytic or hemoglobinopathy type situation. So we're sort of like warming up to an idea of what we're dealing with here. We got splenomegaly and then this smear that's giving us a lot of answers. This is just a really boring slide making that little circle bigger. So, but it's basically just eliminating those other hemolytic issues and hemoglobinopathies it could be. So moving on to imaging. So everybody would love for their imaging to support their exam and things like that. Chest x-ray is not really doing us much good, but we didn't really expect there to be anything in the chest x-ray. He was clear of auscultation, doesn't have any heart or lung issues. But wait a minute, what is all this business? That is a massive spleen, and that spleen correlates with our exam, which is very helpful. So you have this heterogeneous spleen with possible infarctions, but the surrounding organs appear normal, which is very good. Of note, at this point, there was a discussion regarding whether or not this is a neoplastic etiology because of the appearance of the spleen. However, with the labs and with your exam and things like that, it really is not consistent with neoplasm as much as it is this hemolytic process. We have so many other answers for this as opposed to saying, hey, this is a neoplasm. So I think at this point we should review, right? We have all this information. So we have a hungover dude that gets on a plane and barfs. Thank you, that's fantastic. But then he gets belly pain. Oh, what is the deal? So I want to come see somebody who's gonna have all the answers and tell me what's wrong with me. Except I get, you know, a resident, which is fantastic. Baby doctors, right? But that's cool because you're a clinical monster. You've already figured it out. Like, seriously, you discovered that he's got hemolytic, parasitic anemia with all of these labs. It's most likely related to a hemoglobinopathy, thanks to your smear. And then he's got splenomegaly, plus or minus infarction. What does this remind you of, everybody? Sickle cell disease, yay, wait. Dude, he's 32. No. He can't be like sickle cell disease presenting like this at 32. Most people don't have a functioning spleen by the age of 10 when they have sickle cell disease. So what is it? Oh, it's sickle cell trait. Oh, what did I do? I did that one. Okay. asymptomatic. Sometimes you'll have some painless diarrhea, or like maybe you get massive sickling and sudden death. What? Exactly, Rob Burgundy, what? Okay, when does this happen? High altitudes and dehydration. Does that sound familiar to our history? Yes, he was on a plane and he was dehydrated. So the missing link in this case is the plane. There actually are about 34 documented cases of high altitude included induced splenic infarct since 1985. I'm thinking there's 35 now if you catch my drift. But just staying here, I think we as a group solved our case. You have some alcohol-associated dehydration, you have high altitude with partial pressurization of airplane, hemolytic anemia, and an Afro-Caribbean male. So this really speaks to me of like sickle cell crisis with splenic sequestration. So what I would order would be a hemoglobin electrophoresis and see if that would support my diagnosis. These are my citations, and this is